We have a great presentation today from two community activists. I want to welcome you to the Reunion Project's Toolkit series, Channeling the Challenge of Change. Welcome, everybody. Hope you settle in. We've got a great presentation today, the Reunion Project's Toolkit series, Channeling the Challenge of Change. We'll get started in a few. Feel free to introduce yourselves in the chat. We're excited to see you all. We're excited for today's presentation, Channeling the Challenge of Change, which is part of the Reunion Project's Toolkit series. Welcome, everybody. My name is Heshi Zinman. I'm going to be your moderator for today's program. We'll get started in a few. Feel free to introduce yourself in the chat. It's nice to see you all. So welcome. Again, my name is Heshi Zinman. I'm a long-term survivor of HIV, and I'm going to be your moderator for today's program. So let me tell you a little bit about the Reunion Project. We were founded in 2015 by activists living with HIV. The Reunion Project is the National Alliance of Long-Term Survivors of HIV. We collaborate with local and national HIV advocates, providers, and researchers. And together, we convene and we connect individuals and communities, sharing our stories and our experiences of survival and loss, while honoring our past and developing successful strategies to live, support one another, and thrive with HIV today and into the future. So my picture is right in the middle on the top row. I am the last, I think I'm the newest member of this Reunion Project Steering Committee to join the board. And I did so because my focus as an activist since 1987 has been around getting people the information and the knowledge they need to help them navigate the systems and the structures to live healthfully and to thrive long-term with HIV. My crowning achievement around information was the creation of the AIDS Library of Philadelphia back in 1987, the AIDS Information Network in 1992, and most recently in 2010, the LGBT Elder Initiative, where I focused on issues of aging with HIV and working to make the aging services network more culturally competent to address the needs of LGBTQ people and people living with HIV. So next slide, please. Thank you, thank you. So we would like to thank our funders, without whose support we could not do this important work. We would like to thank Gilead, Vive Healthcare, BMS, Bristol Myers Squibb, Avita, Janssen, Walgreens, Merck, and Broadway Cares Equity Fights AIDS. Thank you, sponsors. So a few housekeeping rules. The event is recorded. It is being recorded, and closed captioning is available. Please, we're going to be doing Q&A, and so there's the chat feature to ask questions. Please use that feature. And also, listen, if you wish to remain anonymous during this program, then please turn your video off and consider renaming yourself on Zoom during the program. I'd like to remind you, please take a moment. We're going to be dropping an evaluation in the chat towards the end of the program. Please, please, please fill out the evaluation because it really does help us. It helps inform the Reunion Project as to what your needs are, programming ideas, and whether or not today's program was effective. So again, thank you, and please don't forget your evaluation form when it's dropped. So again, welcome to the Reunion Project's Toolkit series. Today's program is Channeling the Challenge of Change. Our speakers today, we're going to get to that. So our speakers today are Marcia Johnson-Lett and Lisa Johnson-Lett. So let me, I'm going to give you a brief bio. We're going to hear from these speakers. We're going to do Q&A with Marcia, and then we're going to go on to our keynote presentation by Lisa Johnson-Lett, and then we will do some more Q&A with Ms. Lett and Ms. Gillette. So Marcia Gillette has a Master's of Social Work and a Bachelor of Arts in Psychology. Marcia is a long-term survivor of HIV, being diagnosed in 1994. Prior to conceiving 2 healthy infants, she is she went to work for the AIDS Survival Project in Atlanta, Georgia as an outreach coordinator and later a program manager. She works as a volunteer, as a community health worker and support worker, facilitator for several organizations. She's political. She's worked on the Georgia 2000 Consensus Complete Count. Ms. Gillette speaks from her heart, sharing courage, strength, and hope. She's passionate advocate to remove the walls of stigma, one brick, one person at a time, that surround HIV and mental illness due to ignorance and misinformation. So with that, I'm going to turn it over to Marcia.
Thank you so much, Heshi. I'm going to talk a little bit about aging in the community. When I first think about aging and HIV, I think about, first of all, my losses. In 2001, I lost 11 friends and colleagues to HIV complications. And many times today, I'll go to Facebook sporadically, like I would go to a newspaper obituary section just to find out who is still alive, who's still with us. Because I've lived in so many states, it's difficult for me to keep up with each person's passing. But it's not just the losses of those that are dying from HIV complications, it's those allies, the partners that we learned to love, that were partners with people who were living with HIV, allies, and even our own family and friends who aren't even affected other than through us with HIV and AIDS. There's that survivor's guilt that I feel because I've lived longer than so many others now at 29 years, almost 30 years of living with HIV. But yet I also have outlived my mother and my brother, who were supposed to live longer than me. I was the one that was expected to die before them. So there's that guilt behind that. The other fact about it is, as a long-term survivor, I have been concerned about the effects of the medications on my body. And ironically, CDC has stated that those of us who are long-term survivors, are approximately 10 years older than what our chronicle age is, which would mean that I am at the age of 52 am experiencing health conditions more like the person who is 62. And this comes into play in all areas of my life when I go to doctors outside of the HIV realm, especially because they look at me and they're trying to figure out how to treat me. And I have to remind them they need to consider in the treatment plan that which they would consider for someone who is 10 years older than myself than what I am. So with aging with HIV, there's those complications too, because these medications have been very good for us, but they're very toxic at the same time. I would like to say maybe I have dated older men due to the fact that my body thinks it's 62 and I'm only 52. That could be a fact. I, as a individual, have mild cognitive impairment and ADHD. But before this was diagnosed, I was tested for dementia, Alzheimer's, and hand HIV-associated neurological disorder. Those are all things that we are experiencing. Normally, you would not test a person who is only 50, 51, 52 for those conditions, yet that's part of aging with HIV, is experiencing those conditions. And also going from being 20/20 in my eyesight at the age of 42, and going from that to needing to wear glasses and having them bifocals, and then 7 years later having surgery for cataracts when I had perfect vision before. Also experiencing osteopenia at a young age too, at 47 years old, being diagnosed with osteopenia. Living with HIV still has many stigmas and discrimination along with it. And unfortunately, we have to deal with that as individuals living or affected by it when our loved ones are seen by doctors. This past Memorial Day, I was seen in the emergency room for a broken leg, but a Caucasian man had to advocate for me to get painkillers before I was administered any painkillers for a broken leg. The doctor said that they were going to send me home with a prescription of painkillers at 2 a.m. in the morning, but they were not going to administer them at all. Fortunately, they did administer them. Unfortunately, they had no effect on the type of pain that I was experiencing at that time. I was also confused because that after Memorial Day weekend, that Tuesday, I got a phone call saying I had to get to the hospital, get to the doctor right away because I needed surgery. And I couldn't get there that Tuesday, so I went Wednesday, and the doctor walks in and says, "You don't need any surgery." And this, I saw a red flag here because I was not assured that this was actually the case. But every doctor who would come in would say that I need surgery. And again, this doctor would say I didn't need surgery, despite the fact that I was giving all the facts and symptoms of which could be a ligament disorder going on in my knee. Nearly 4 months later, when I went to another doctor, he finally did an MRI and confirmed that my ACL was torn, the meniscus was torn, and what he thought was part of my kneecap was on the backside of my knee. We later found out when I went to the third physician, because the second one refused to treat me because his nurse felt like I was non-compliant to my physical therapy because I had not attended in a week, but he would not allow me to say that I wasn't attending physical therapy because the physical therapist was on vacation. I mention all these things because there's a lot of stigma that goes on here in the Deep South around HIV, being Black, and being a female, and what you should expect with that combination. The third surgeon evaluated me when the steroid shot did not work in my knee. He did surgery this past Thursday on my knee. Found he did not expect to repair the ACL, but ended up having to stitch it back to my bone, do the medial and the lateral meninges. Sorry for the pronunciation. If it is this difficult to get quality of care due to stigma and discrimination, my fear is I don't have my mother anymore, who was a nurse and a strong advocate for me. I don't have any siblings because my brother is gone. I only have my daughter and my son, and they're not even in the same state with me. So what happens to me should something happen and I don't have someone to advocate for me? What happens to the individual who does not know how to advocate for themselves? Are my concerns with aging and HIV. For quality of life, over the years, it has changed over and over and over again due to many adjustments I've had to make as I traveled this journey, some good, some bad. What my quality of life today is thriving. And by this, I mean doing the best way I possibly can with all my health disparities while enjoying the small things in life. Because what I have learned is that I have been so busy working many times or sick or being a parent that I've missed out on the small things. And those are the things that we like to remember, that we need to hold near to us. So, Kashi.
Right, sorry. So you've had a time over these past years, but let me ask you, you're here with us today. What is your secret sauce? You've been diagnosed for some 30 years, and you're here. What have you done in spite of some of these issues? What have you done over the past years to stay, to be here? To be
One of the first things that I've done is I first of all, this I refuse to see it as a death sentence because my mother had been involved with HIV and AIDS in the 80s as a hospice nurse, and as a drug rehab counselor. She served both people who were dying and people who were being infected. So I knew, because the science of things, it didn't make sense to me that we had to die. I felt like there had to be a way that we could live. Another way is getting involved in community, reaching out. I was given a mentor when I lived in Atlanta, Georgia. I joined support groups. I went to people who were long-term survivors, some still with us, but most are not with us. And I asked them, what was their secret sauce? How did they live with HIV and thrive?
And so, having a support group, having a strong community that you could fall back on is always very helpful. Let me ask you something. You mentioned early on that in the early years you lost a lot of friends. Has it been difficult making friends? I know myself personally, I've had to I had to reinvent myself several times over the years because I had groups of friends that had passed away early on. So in your case, has it been easy to create new friendships?
Well, friendship for me was difficult because I've grown up and lived in 12 states. I never lived in one place longer than 3 years. So I was always reinventing myself. But once I became HIV positive and I started losing people who were also positive, I had my own nonprofit, for example, and everybody that was on my board is now deceased. Losing those individuals, I'm just now getting in touch with my emotional health and realizing that I have put a barrier up against myself and the world so that I would not get too close, so that I could keep this barrier. Somehow that would help me keep from grieving as much and getting as close. And now that I've discovered that I have that, I'm working on tearing it down because I want to be my most authentic self.
Great, great. And yeah, I mean, being being the most authentic sometimes makes us vulnerable. But it's really important to have people in our lives, and so to go the extra mile and allow yourself to be vulnerable, to meet new people, I think is really a positive thing. So with regards to the aging with HIV sooner, we know that in the United States, greater than 50% of people living with HIV are over the age of 50. And so how, when you are addressing, when you're going to your doctor and talking about some of these issues, do you explain to them the fact that there is some data to suggest that aging occurs more rapidly with HIV and that they need to be considering that?
Not only do I explain that to them, but I bought this super smart scale. And this scale looks at my body weight, the water mass, everything you can think of. It looks at it. And it doesn't have me at 62. It only has me at 57. The last time I was able to get on the scale. But that even it still is an indicator that I am actually older physically.
Marcia, excuse me. Hey, folks, there is background noise here. If you are not speaking, could you please mute yourselves? Wherever that noise is coming from, please mute. Thank you. Thank you. So Marcia, I'm sorry, I got a little waylaid with all that scratching.
No, that's all. You could just repeat the question, please.
Yeah. So with regards to the fact that we have some data to suggest that people with HIV age more quickly, how do you address that with your docs when you go to see them?
As I said earlier, when I was talking about a treatment plan to the third physician, I told him that he needed, in the course of treating me for this broken leg, the healing time he needed to, and the treatment plan needed to take in consideration that my body is not, I'm 52, but my body is not.
62.
My body is older. Even my scale says that I am 5 years older than what my chronological age says it is. Now, CDC gave us an estimate of approximate, so I would assume it's somewhere between 57 and 62. But I try to inform them of those issues and urge them to consider them when they're looking for diagnoses, because there's oftentimes diagnoses that they won't look for because I'm a younger person, but they may be relevant for me because I'm actually aging with HIV.
Right. So Marcia, I'll tell you, you have, you're very empowered. You got a lot of information, which certainly makes me happy as an information geek. But clearly having all that information allows you to have honest communication with your providers. And so I want to thank you for sharing your perspectives. And I'm going to move us on to Lisa Johnson-Lett. And I'm going to tell you that Lisa Johnson-Lett is a military veteran who served in the U.S. Army for a decade. She's also a graduate of Metropolitan College of New York, attaining a Bachelor of Arts in Professional Service, in Human Service, and an Associate's of Art in Speech Communications. And she is a nationally recognized speaker who is a member of the Toastmasters Speaker Bureau. Lisa is a champion for the HIV/AIDS community. She dedicated her life to HIV/AIDS advocacy while living with HIV since 1995, where her focus has been on Black women, reproductive justice, and trauma-informed HIV-specific care. She is a product of selfless service as she aims to transcend the lives for the HIV community. Thank you very much. And Lisa, it's a pleasure to meet you, and take it away.
Hello, 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 everyone. I am zooming in to you all the way from the state of Sweet Home, Alabama. I welcome you today to Channeling the Challenge of Change. That's a challenge by saying it itself, right? Channeling the challenge of change. If you don't know by now that you were an advocate, you do now. We are all patients at one time, and we advocate for adequate standard of health and quality care. Today, we are channeling our voices to the challenges of change as we age. Furthermore, I am going to explore with you the challenges of change, aging with HIV. We will identify our purpose, identifying issues relating to people aging with HIV and long-term survivors. We will have some interactive segments where we will discuss the macro level, such as analyzing the national landscape of HIV. We will also analyze the micro sections, exploring personal experience. I came up with a quote: "The failure of clarity leads to the failure of humanity." So today we're here to channel our voices so we can be effective advocates, first starting with ourselves. Then we deal out that healing love to our community. So some of us are HIV advocates living with HIV. Some of us are allies or accomplices. And with that, think about the community itself and the uniqueness within the community. If you could put in the chat, I said 5, if you want to put 1 or 2. However, name 5 distinct reasons that makes the HIV/AIDS community so unique. And within those, you have systemic reasons, you have institutional reasons, you have organizational reasons, you have community reasons, and you have internal reasons. So, think about stigma, think about systemic racism, think about all the overlapping intersections that comes out. And I give you maybe about 2 minutes to put those. Someone said compassion. It says the HIV community managed to create massive systemic change. Supporting each other. Self-empowerment, history. Resiliency. Stigma itself. Love, education. AIDS service and organizations. One common thread is trauma experienced. A group of diverse individuals, transparency. Thank you for that. Someone else said family, nothing about us without us. So as we dive and we explore, let's look at this. I don't know if anyone have heard of AIDS View map, but if you could you could Google AIDS View. And when you put in AIDS View, it allows you to put in your zip code, and you can see the prevalence rates of HIV in your prospective areas. And I left at a glance on here, so you can see the darker the area is, shows the highest prevalence rates in those areas. And it's supposed to be all red, and some of them look dark burgundy, almost black. That means it's a very high prevalence area. There's also areas that is white or light gray. That doesn't mean that there's no HIV in that area, but what it does mean that it may be underreported, and maybe 1 or 2 or 3 people may have HIV, but if they report it, they might out them. So therefore, they just leave it as gray and white. Thank you. Now I want to talk about the national landscape. So on a macro level, I don't know why these lines are through here, but on a macro level, approximately 1.2 million people in the United States have HIV. About 13% does not know that they have HIV and they need testing. Greater than 50% of people living with HIV in the United States are over the age of 50. Thank you. Statistics. According to Health Resources and Services, HRSA, nearly 47% of all Ryan White HIV/AIDS program, RWAP, were aged 50 and older. According to a blog by Dr. John O. Merman, CDC, and Dr. Sean Cahill of Fenway Institute, researched their findings and revealed about 290,000 people are aged 55 or over, which is equivalent to 1/4 of all people living with HIV. Persons aged 50 and over account for 1/5 or 18% of new HIV diagnoses recorded since 2013. Between 30% and 50% of people with HIV will experience some form of mild to severe neurocognitive disorder, such as attention, memory, sensory, and perception, inflammation, language, and/or motor skills. Thank you. Now, as a board member of the Positive Women Network, it would behoove me not to talk about the women on the scene. And here is some differences with women living with HIV. Women living with HIV may experience onset of menopause earlier than the average woman. The average woman begins menopause between the ages 45 through 55, but the average age is 51. Due to immune system response, women with HIV may have more severe symptoms, but research, as I studied, stated that more research is needed to be determined. That says a lot within itself. Thank you. Overall challenges. Let's remember that an undetectable viral load does not always equate to total good health, because HIV is a virus causing inflammation and it affects other parts of the body. And just as Marcia was saying earlier, having potential for dementia, HIV-associated neurocognitive disorder, hand, diabetes, osteoporosis, cardiovascular disease, mental health challenges, and isolation. Once converted, the body is always attempting to rid HIV, which means the immune system is always consistent and constantly activated, causing chronic low-level inflammation throughout the body, and showing signs of premature aging, aging too early, causing heart disease, heart attack, stroke, liver disease, non-Hodgkin's lymphoma, lung cancer, type 2 diabetes, and kidney failure. Thank you. Now we're going to talk about more challenges. And I want to ask each and every one of you, do you see yourself in this circle? And if you do, you could put it in the chat. And I'm going to start with the circle right above called ageism and HIV. Has anybody experienced ageism? Oh, you too old, you can't do this, or you can't do that. Related stigma, discrimination. A little personal story, not about me, but of someone, a few people very dear to me. See, we wasn't expected to live. And now that we are, we shouldn't have to, but we have to be educated to prepare our providers to care for us. There have been some people that I know personally that have went to rehab for different various reasons, but it was not associated with HIV. There have been people that has passed away because practitioners, that's not an infectious disease, refuse to go to the rooms of the people living with HIV in the rehabs. They refused to give them medical attention when they needed it. They refused to take labs because they didn't want to touch them. And that's heartbreaking. And there are very few rehabilitation and nursing homes in the state of Alabama that will accept people living with HIV into their facilities because the cost of medications is too expensive to get. And if you don't have a family member, or if you don't have a peer support, or if you don't have a case manager, somebody outside to get medicines, they're not gonna get it for you. Another one is social isolation. And what does that look like? You experience loss, you're aging yourself. You may be experiencing some symptoms that you never experienced before because you may not want to talk about it. You deal with it, which may cause that isolation. And dealing with that isolation mentally, that also brings you to the next one, loneliness. If you isolate it, then you're lonely, and then you're thinking about all these different things, and then there's depression. Then the older you get, there is some people experience elder care. And who's going to care for you when you can't care for yourself? And those things can be scary. Then you have falling out of the continuum of care. No delivery of health services. And then you have lack of bedside mannerism, the sense of lost community. Again, if you're not infectious disease, the nurses, practitioners, they're still thinking like these old, antiquated, outdated ideas that you could catch. No, you can't catch. You can catch a ball, but you can't catch HIV. But they're still thinking like that. Then you have polypharmacy, which is another one that I'm dealing with. And I go from not taking no medicine to the 1 pill a day. And then after the 1 pill a day, then I have all these other comorbidities. And now I have pharmaceutical polypharmacy because I'm taking over 5-6 pills a day. And if you see yourself in here, please, and if you probably did put it in, please put it in the chat. Next slide, please. So I ended it with the polypharmacy meds. So let's talk about medication challenges. So some of the medications challenges, I've noticed that a lot of older adults that reside in the Alabama area, and probably if it's here in Alabama, there's other places where literacy is lacking. So if somebody have a lower level of reading, is anybody showing them how to even read the labels? Or if somebody speaks a different dialect or different language, do we have labels that can be changed or translated into their language? Then you have to think about storage. Again, I can only talk about the state that I know. And so in Alabama, there's a lot of experienced homelessness. And if you already stigmatized with HIV and you don't have nowhere to store your medicine, that poses a problem because that could lead to resistance of medications. And even if you have some place to store your meds, if you're not living in habitable housing and moisture seeps in and you have mold, well, that moisture is toxic to the medication and then it doesn't work in your body like it should. Then there are side effects. I don't know if anybody heard of sandwiching before, but that's a prime example when you supposed to take your medicine, but some people don't take their medicine because they said their stomach hurt. But again, you didn't really read the label like it should. And the label says you're supposed to take it with food and you don't take your medicine with food. So that's why your stomach hurt. And then some people don't feel like eating. So maybe you could ask your doctor to switch up to medication with less side effects where you don't have to eat with the meds. Or if you have to eat with the meds, sandwich it. You may not want to eat, just take a bite of a sandwich, take a bite of bread, swallow your pill, and then take another bite of bread, take your water, sandwich it. Think about also drug-to-drug interactions. And then there are drug toxicities. And then here we go again, mathematical skills, medication monitoring. When you have at least 14 pills left, go ahead and order that other refill. But if you're not counting or don't count, then it's hard to keep up with those medications. And it's a challenge to get the refills that you need. Next slide, please. So community engagement. If you could put in the chat, define long-term survivor. What is that? What does that mean to you? And then what are some unique needs of the aging with HIV population? What are those unique needs? And so remember in the beginning, I said the failure of clarity leads to the failure of humanity. So we want to deep dive with these questions so we could get more clarity. So somebody said that over 20 years positive, it defines as a long-term survivor. Long-term survivors, isolated aging, many medical professionals are now younger. And then somebody says, I'm still here regardless. That's power. We here. Whether you like it or not, we here. And then it says so many definitions. Wait a minute. Let's see. It says not being able to refill medications. And it says long-term survivors, some say over 15 years, but we also have verticals, people born with HIV. So yeah, so if you was born with HIV and you 5 years old, guess what? You still aging with HIV, right? And I want to say, you know, not taken away from the HIV community itself, but I learned from the Reunion Project that if you impacted in any kind of way, whether you are a family member, whether you're a nurse, whether you have HIV, whether you don't, like my children, they're long-term survivors with me because they with me for the long haul. So they're long-term surviving with me. That was a unique way of looking at it because we're talking about in some places building those neutral status relationships. And what better way to build those neutral status relationships is looking at long-term survivors as those impacted with HIV who are also our allies. Then it says, you know, what are some unique needs of the aging with HIV community? And for me personally, like I said before, they aren't ready for us. And the unique needs showing me is that no one shouldn't die in a healthcare system because no one don't want to go into their room, because no one don't want to touch them to take their blood. We need to have, I feel, our own gyms. We need, and I don't want to say, oh, we need to be segregated. No, but we need our own. We are a community within itself. And we may have things that we need that other people don't. And we already have people not accepting us. And so we need to have a community of people that accepts us for who we are. And so we need rehabs, we need nursing homes, because we may need elder care one day. Next slide, please. So now I want to talk about getting to know some of our Alabama members. So I am able to facilitate a group here in Alabama. And everybody couldn't be here today, but we have about 12 people that comes. It's called Let's Talk Community Conversations. And it's an HIV and aging support group. And the members consist of 7 women and 5 men who define long-term survivors as the group itself. The 12 of us consist of over 140 years of lived experience as SMEs, subject matter experts. There is 2 testimonies. It says, we overcame and still are overcoming. And another person said, some of the challenges of aging is experiencing the onset of things you have never experienced before. So I want to now identify some of the unique needs that the group have found. Some people said that some of the unique needs are skilled professionals who are not afraid of HIV to assist with chronic conditions not related to HIV. An example of that is I went to go get a sleep test done, and I feel it's not factual, but I feel that the person that was in charge of putting the probes on my head read my chart because she refused to touch my head. And she had a long, I want to say like I don't know, it was like a long stick. And she put the probes on this long stick and just started digging in my head, just digging in my head. She didn't want to touch my scalp or nothing. And I just sat there and took it. I didn't advocate for myself. Why? I didn't feel like I had the voice that I have now. And I just took the pain, and it hurt, but I need to go through with my sleep apnea test because I do have sleep apnea. But again, this is just one example that has happened to me, and I wasn't in-house in rehab. It was an overnight sleep study, and the lady didn't want to touch my head. Also, nursing homes and rehabilitation centers free of stigma and discrimination. Fitness centers and recreation adult community care centers for people 50 and over with HIV. Housing who are felon, hopper friendly for people who are 50 and over with HIV. I said this, dental hygienists who are HIV friendly. So just recently, about 2 months ago, 3 months ago, anyway, I can't remember. I had to go for emergency, and I had to go get my teeth taken out. And the first thing when I went to the doctor, because I have insurance through my job. So when I went to the private dentist, the first thing she asked, the clinic, no, she said, I see you have HIV. And the first thing I said is, and then says, well, what I was trying to say is, the clinic who serves people with HIV is free. Well, since when the doctor who does your chief talk to you about finances? I usually they talk about finances right before I go out the door. So I had a little bout with her, but I continued to get my teeth done, and she continued to see me, and I got the adequate care that I needed. And then also, we have done away a lot with support groups and retreats, and we need to bring that back. Next slide, please.
Because of COVID.
So now I want to talk about the micro, personal. So my purpose for this is to redefine our purpose pertaining to what situation it is. So there's different situations, there's different challenges, and my advocacy changes accordingly. We have to bring awareness. We have to be able to clarify and not be in denial. And it's hard, if you're newly diagnosed or even pertaining to aging. Some of us may be denial. I may still think it's a hop, skip, and a jump, and I can put on my roller skates and skate here and do this. And no, I can't. Not anymore. So ageism is real. Polypharmacy is real. Comorbidities. I never had diabetes before 2015. I have diabetes now. I have COPD now. And when we was talking about having those, I think one is called a gerontology evaluation. I was on a conference call last year, and someone was talking about having a gerontology assessment. And I thought about that. I've been having changes in my body. I've been experiencing some things that I haven't experienced before. I'm gonna go ahead, I'm gonna go down to the VA because I'm a vet, and I'm gonna go ahead and ask for that gerontology assessment. The first thing they asked me is, why are you here? And I says, I need an assessment, and you gave me an appointment. Well, you get ready going to a nursing home? No. Do you have challenges with your ADLs, activities in daily living? No. Well, I'm sorry to waste your time, but we can't see you. And I says, why? I said, I'm living with HIV. My body's aging 10 years prior to the way it's existing now. I am, at the time, I'm 48 years old, and my body thinks I'm 58. I'm having different kind of issues, and I want to be screened, so maybe we can alleviate some of these issues. And then they said, sorry, the VA is not set up for that. So I go to my asthma clinic. My asthma clinic tells me, we want you to start pulmonary rehab. But before you go to pulmonary rehab, you need to do an assessment. Well, tell me why they gave me the same assessment that I was asking for at the gerontology clinic, but I was able to get that same assessment before I started pulmonary rehab. The thing, bottom line is, I was able to get the assessment, but you shouldn't have to go through all that. You shouldn't have to go through all those hoops. And then values. If I have a closed mind, I'm not gonna really get nothing done. So I continue, one of my values that I strive to have is to have an open mind, and that my values change due to my life events. Yeah, I'm not trying to go to Six Flags to get on a roller coaster and I'm having heart palpitations. And then systems that work in my favor to enhance my quality of life. What does that mean? Does that mean I need to change my insurance to get me some health care that have the YMCA or the, what is called, my sneakers, where I could go get free gym membership and to work on my
silver sneakers.
Yes, to work on my health. So we have to think about those systems that can work in our favor. And then skills, what skills do we have? Let's utilize the skill sets that has developed me over the years to create the foundation for my purpose. And what is the foundation? 27 years lived experience as a seasoned advocate, subject matter expert, 30 years as a public speaker, 10 years of military service. All these adds up. Next slide, please. So now with all of this, let's determine our next steps. What is our next steps nationally as we age with HIV? What is our next steps in our local body? What are we going to do with this information locally in our local ASLs and our local CBOs and our local support groups? What can we do to think about edifying us as we age and giving us power as we age and making people see us as we age, because we're not going nowhere. And I just learned that we are what, the baby boomers of HIV? Like, it's hard. It's a hard pill to swallow. But what, HIV in the United States is only 42 years old. So if HIV in the United States is over 42 years old, a lot of us are gone. A lot of us is not here anymore. But we are the next generation with the 1 pill a day, now a shot for those that can get it. We are the ones that have to teach people that we are here, that we're still alive, and that we're thriving. And we continue to be who we are, and we continue to show up. And I think that's it. This is the sources of information we are found everything at. You can look up AIDS View. That's where I got the AIDS View map from. CDC, the Southern AIDS Coalition, the HIV in the United States, Deep South Trends, United States Statistics, HIV.gov, and also the Well Project. And I thank each and every one of you for being here.
That was a great, awesome presentation. Thank you, Lisa. You know, there was so much information in that presentation. I do a lot of work with aging and HIV, and I do a lot of work with the AAAs in the States. So as a person aging and thriving with HIV, what would you want folks in the aging world to know about your issues? What are your questions for folks in the aging world? And what would you want them to know about you as a person living with HIV?
So when you talk about person in the aging world, just anybody aging or
So-
people in our community?
So folks, no, not in our community, folks in the area agencies on aging, the state, there's a county office on aging, there's area agencies on aging, there's folks that just do aging stuff. Baby boomers are going to be needing to access services within the aging world. So you're coming in, you're meeting for the first time somebody who is an aging case manager, not an HIV case manager. What would you want them to know about you as a person, a long-term survivor of HIV, and about you, and what are the concerns that you have about how you may get treated within the aging network as a
Well,
person living with
If
HIV?
I was talking to a case manager that's dealing with aging, the first thing I would ask, have they have any experience with the HIV and aging community? If they have not, and even if they did have experience, I would still share some of my experiences with them and let them know. I would need somebody to advocate. If we go into a rehab, I need somebody to advocate for my medicine. I might not have no family members around. And you get high blood pressure medicine, you may even get diabetes medicine. But they talk about the cost of medicine for HIV is too much money and it's not accessible in those places.
So I just want to be clear, because being a northerner and an East Coaster, it's hard for me to understand that there may be rehabilitation centers, rehab centers that do not provide HIV meds to folks who come into that agency for service. Aren't there laws to protect Medicaid, Medicare systems in place to guarantee that you will get your HIV meds?
They should, but it's very difficult. It's hard. As a peer support specialist, if some of the people didn't, if I wasn't their peer support specialist and able to get the medicines to them, they wouldn't be able to get the medicine.
Wow, that's crazy. And so systemically,
Mhm.
you cannot get HIV meds from certain institutions, certain systems, like the rehab system.
Mhm.
That's the case. All
And
right.
then also, there was a situation that's sticky, like you can't. So if the client knows that they're HIV positive and they tell you that they can't get their medicine, I'm not allowed to even go and tell them, hey, y'all need to get them. Yeah, I'm not even allowed. I snuck and got their medicine and brought it back to the hospital. Yeah.
Is there ombuds people?
Yes, we do
Somebody,
have that. Yes, we
do-
do have that.
you do have.
I've seen it. Put it like this. I don't know if it's in use, but I've seen they have flyers and phone numbers that you can reach out.
Right. So we know that in long-term care facilities, if you feel that you're being discriminated against, you have the right to have a long-term care ombudsman, ombudsperson, come in and advocate on your behalf with the administration of that long-term care facility. Is there such a thing in rehab centers as well, where you can get an ombudsperson? So to be able to advocate for the fact that you need to have your HIV meds or else you're going to die.
I have not seen those posted.
Okay.
And I usually find out after the fact. Either the person has passed away or the person is discharged from rehab and is back on the streets. And I happen to find them on the streets later on and they tell me what happened.
Right. So let me ask you something about the conversation, the support group. Did you develop the support group, or you go to the support group?
I developed.
You developed it.
Yes.
So how will this group, if I come into this group, what are some of the ways that this group will support my wellness, my ability to thrive with HIV? What are the things that you do?
What I do is in this group, we support each other by putting topics out and we talk about those topics. After we talk about those topics, we also, through those topics, find out each person's need. And we link those people to the actual supports that they need or resources they need within the community, whether if it's food, whether it's a policy support group, whether it's a co-ed support group, because to go to this support group, you have to be, it's clinical. Like it got to be attached to the actual clinical setting. So if they need other things outside, we give them resources, resource them out to other groups. And a lot of people within our Let's Talk group, we are also connected, you can say by the hip, because we're in other groups together.
So folks who come into this group, you would say that they have formed relationships?
I feel that we have an intimate relationship.
Intimate relationship. So you could say that this group is important in helping to counteract isolation.
Yeah, very much so.
Loneliness.
There are some people who have experienced isolation and loneliness, and sometimes this is the only group that they come
to get support around that.
Yes.
That's really important. And so let me ask you a question. With regards to quality of life issues, what is your definition of quality of life?
My definition of quality of life is understanding and becoming aware of the actual needs. A lot of people, sometimes you may have a broken leg and may not get it fixed, but yet if you get it amputated, there's an actual leg out there. You just have to learn how to walk on that, on it. It could be out there, but you have to have the resources. You have to have the know-how. You have to be aware that the resources is there for you to get it.
Right. So having that information and that knowledge is really important.
And I always talk about there's a difference between resources and available resources. Don't tell me about the resources if it's not available, because you're wasting my time.
Understand. Hey, Lisa, we have some questions from the group, and I can see some hands. So I'm going to call on Richard Bass. Richard, you're muted.
Yeah, I had to find the mute,
Okay.
the unmute button. There were so many of us here. I want to share with you a grassroots group, a program that I started here in the Coachella Valley. And it's called PALS, Planning Ahead for LGBTQ Seniors. And I'll put the website on the in the chat. Whether or not you live here, the program will give you a framework of the conversations, of the topics we need to have in order to plan ahead. And Lisa, you did the same thing. This isn't exactly clinical, but at the time when I turned 70, I needed information. And so I started this program, and it just kept building and building. And you're right, these conversations, because they're more personal, they create a really close, intimate network of people. And so no matter where we are, right, we can always start with one or two people to begin having these conversations, and the word will get out. So everyone is right on. And Marcia, someone mentioned at the time that on the chat that people need the Advanced Healthcare Directive. Well, yeah, one of the topics we need to have is the legal documents, for instance, so that someone is legally, there for us to advocate. Anyway, it's a long process. I would love for you to keep in touch. I'm going to put my the website and the email.
Great. Thank you, Richard. We have a question from Jerome Edwards. Hey, Jerome.
So I don't have a question. I actually have some statements. It is on some questions that you had asked earlier. With me by working in the medical field, as Lisa was stating earlier, that there are some things that she will have to do by not allowing her job to know and things like that. That is correctly true. With the Alabama Medicaid, they are very picky and limited with services that are provided by peers. So technically, a peer cannot bill Medicaid. We can bill the Ryan White services, but we cannot bill the Alabama Medicaid for any services that basically we provide to our clients. So no, there's not a PALS program here that is in Alabama, nor say if you do have a client that is in a actual assisted living home or in a nursing home, technically you are just a visitor. So they can legally revoke your visitation. It is to their building. So we have to really thread on a real thin line to protect ourselves and to protect our patients. So Lisa and then as myself and myself, we all work together, but we work for different agencies. And there are things that my job don't know that I do for our patients, because it will be as a ethical boundary situation. So
Jerome, I have a question.
yes.
You're in Alabama, yes?
Yes.
And so Alabama has Medicaid.
Mm-hmm.
And so you're not allowed to charge Medicaid for services that you provide to.
No, you're not allowed to charge Medicaid for any type of services because you're not a licensed provider.
Okay, so you're a peer provider.
Right.
Okay, so peers are not allowed to charge Medicaid, but medical providers can charge Medicaid for HIV services.
Okay. Services only, but not for
Peer.
Not for peer.
Not for peer care at all. So all of my services get charged on a Ryan Wright Part B or Ryan Wright Part C. It depends on what type of services that I'm doing for my client.
Got it. Got it. So let me ask you something with regards to aging with HIV. Have you, and this, I guess, question is for Lisa, have you accessed or looked into your state or county aging services, aging department, to see what benefits and services you can get as an individual? Never mind HIV, but just what are the services that they can provide you as an individual who's getting old? You know, because I know the work that I do in Pennsylvania Department of Aging has recently recognized HIV as a chronic manageable disease. And so HIV is very much in the profile of the Department of Aging. So when you go to a county office on aging, you can have HIV and talk to them about what services can you provide to me as a person aging with HIV. So I guess the question is, has that work started to reach Alabama?
No, for me, I've just siloed myself at the VA system. I haven't looked outside of the VA because that's where I get the majority of my care from besides dental.
Right, right. And they do not discriminate against HIV. So you can get all your meds through the VA
Yes.
without a problem.
No problem.
I have a question from Melanie Ross, and then I think we're coming to a close. So I'm going to take one more question from Melanie Reese. Hey, Melanie.
I have my hand raised because you had asked Lisa about working with the aging community, not HIV and aging, and what do you think needs to be done? Well, one thing I think that needs to be done is there has to be advocacy in lowering the age that the aging community uses as you are able to
As a mark.
yes, that you're able to access their services, because we say 50 and older in HIV, but
That's not
some
that's not
some is 60, some it's 65.
right.
You know,
And
it's not universal, even though the Older Americans Act says 62. If you go to New York and you want a senior pass, you have to be 65 to get a senior pass. Okay.
That's a great point. That's a great point. And I think it varies from state to state. I know
It varies, but it needs to be universal.
it needs to be standardized.
And that's an advocacy issue that we as people aging with HIV need to see. I'm 70, so I can get those services, but I'm not just concerned about me. I'm concerned about even the verticals who are under 40 need these services also. So
Right.
those are things that we as a community need to do across the nation.
Great point. And that the Older Americans Act comes through the Administration for Community Living, the ACL. And so that advocacy around standardizing the age for older Americans needs to be directed towards the Administration for Community Living. So that was a great point. Thanks, Melanie. And we're going to wrap up now. Heather, do you want to bring us back to the slides? So first of all, I want to thank Marcia and I want to thank Lisa. They were awesome presentations, chock full of information. And again, knowledge is power. You've probably heard this many times. Knowledge is power. And having the information and having the access can really help you to thrive long-term with HIV. I want to tell you about some upcoming Reunion Project events. On November 18th, 19th, the end of this week, we have the first ever Reunion Project in-person town hall in Houston, Texas. I'm fortunate to be on that working group, and so we're really excited about this, and I look forward to it. And then December 6th, we have the Reunion Project Virtual National Town Hall. More information will be coming about that. And it is again, as Jeff Berry says, our in-person town hall is the first one since pre-COVID. Does everyone remember pre-COVID? Okay, pre-COVID. Next slide. Attempted humor. So I got to tell you, and Lisa, thank you for reminding me, you know, the Reunion Project really, first of all, wants very much and needs to hear your feedback, not only about this program, but about our programs in general and the work that we do. And so we really invite you wholeheartedly and sincerely to connect with the Reunion Project. And there are 5 social media and communication addresses. down here. I'm not going to read them. This will be the slide that's kept up. So if you want to copy any of these addresses, good deal. And again, I want to thank everybody for joining us. These toolkit series are new and they'll be forthcoming. This was a great series. Thank you, Lisa. Thank you, Marcia. And thank you, everybody, for joining us. And we'll see you next time. Oh, happy Thanksgiving to all. Thank you and take care.